My charge is to talk about what happens when you leave the operating room and what to do with these patients and when things don't quite go so correctly. So the postoperative course after shoulder arthroplasty is really set by preoperative expectations. We have patients who might be relatively sedentary, all the way to patients who want to do aggressive recreational activities, and postoperative management really needs to be procedure specific. We may not manage an isolated hemiarthroplasty in the same way that we would manage a sedentary patient with a reverse shoulder arthroplasty, because the key for us is really a balance between what we do intraoperatively, which is restoration of structure, and what our patients need, which is recovery of function. And to that end, there's really a concurrency in these phases of recovery. When we give talks to our residents and our fellows about the postoperative management after a shoulder arthroplasty patient, we talk about a period of immobilization. In general, some people use some type of a device or a sling, and the amount of time is really variable, again, depending on the procedure. There is passive motion, and I would say that most people, at least in the United States, do use at least a dedicated physiotherapist, but around the world, many people allow passive and active motion to occur concurrently. And then what patients really want, which is strengthening, as we would say it, in the parascapular, cuff, deltoid musculature, and also patient-specific activities. We have to be able to return them back to what they want to do, but at the same time, prevent complications. The complications after shoulder arthroplasty really can run the gamut. But if we think about this, the etiologies can be divided into either biologic complications or mechanical complications. And so we'd like to really talk about these and give you an idea of how to think about it in a way that it will be beneficial to your patients. The biologic complications involve things basically that are the soft tissue inherent to the patient. Infections, rotator cuff failures, neuropathies, whereas the mechanical complications involve things that happen to the patient. Fractures or instability of the joint or even component failure. So infection, as a biologic complication, this is really the number one complication we all seek to avoid. So we know the incidence of infections with primary arthroplasty or reverse arthroplasty is roughly the same. And with most of these complications, we're going to be talking about resurfacing both sides of the joints. We know that hemiarthroplasty can fall into the primary category. So if we say that the incidence of infection is roughly anywhere from 0 to 4%, that's probably accurate. Revision arthroplasty definitely has a higher rate of infection. And either way, regardless if it's a primary or revision arthroplasty, the organisms primarily involve either Acutibacterium acnes or some type of a staph. Usually it's a coag-negative staph. The treatment tends to be a bit controversial because there are patients that can be treated in one stage. There can be patients that are treated in two stages. There are patients that are treated with just irrigation and debridement, all the way to patients that are treated with removal, spacers, and revision arthroplasty. In our series, over 13 years, we evaluated more than 3,000 shoulder arthroplasties that were performed here, and the incidence of infection was just a shade over 1%. But it was interesting that 6 of the cases had known etiologies, either dental procedures, urinary tract infections, pneumonias or upper respiratory infections. And so as orthopedic surgeons, we need to realize that we're treating an entire patient. And if a patient is coming to you after a shoulder arthroplasty that you have performed with some type of a general systemic comorbidity, be careful, because that can indeed lead to a periprosthetic infection. For us, the treatment protocol in all stages involved a 2-stage revision, and we'll get back to that point. It also involved an infectious disease consultation and a minimum of 3 months between the first and the second stages. The first stage was a component removal, placement of an antibiotic spacer, a PICC line with a minimum of 6 weeks of IV antibiotics, and then a second stage revision. Of these cultures, 4 out of 5 had no growth, which is in keeping with what the literature talks about with regard to infection. Most of the time, we don't grow an organism. But the host is the key to success. George Searney passed away this last year, but George Searney was able to lead us to understand orthopedic infections in general. And the infection treatment should be guided by the patient host, Patient hosts that have no comorbidities are much more successful at treated with component retention or single-stage revision versus those who have multiple factors that lead to an immunocompromised state and an inability to clear that infection. The second biologic complication that happens, which is really more unique to primary anatomic or hemiarthroplasty, is rotator cuff failure. We know that with primary anatomic total shoulder arthroplasty and a polyethylene glenoid, in general, the literature speaks to a meta-analysis of a 1.3 to 2% incidence of rotator cuff failure. But recently, Gilles Walsh has reported that over a 10-year period, 11 to 15% of patients who have undergone an anatomic total shoulder arthroplasty actually have cuff failure. Well, the treatment for this, in general, is a revision to some type of a constrained arthroplasty if benign neglect no longer works. Neuropathy. The third biologic complication, I think, is probably more important than we originally anticipated, because recent work has demonstrated that the incidence of some type of a neurologic or neuropathic pain after shoulder arthroplasty is not as uncommon as we originally thought. With both primary anatomic and reverse total shoulder arthroplasty, that incidence approaches 1 in 5 patients. 10% of the time it's iatrogenic. You know, when I was a resident and a fellow, I was taught that the most common nerve that was injured, if you would say that, or stretched at the time of surgery with an arthroplasty in the shoulder was the axillary nerve or the musculocutaneous nerve. Well, actually, it's probably the brachial plexus, both with anatomic total shoulder arthroplasty and also with reverse total shoulder arthroplasty. Whether this is from positioning of the arm, use of an assistant, retractors, the plexus can see a stretch. The peripheral nerves, mononeuropathies of the axillary nerve, and also the ulnar nerve are very common. We need to be careful, understanding that when we're working in surgery, we're dealing with the entire extremity. Reverse arthroplasty has led us to a different understanding of neuropathies because we're using a semi-constrained joint. And this is a case that I think highlights the fact that undiagnosed pain can be something related to nerves as opposed to components themselves. This is an 80-year-old right-hand dominant male who failed 2 prior rotator cuff procedures. He underwent this reverse arthroplasty that was performed at an outside institution and had really excellent range of motion, was able to elevate to 135 degrees. You can see that the components are really placed well. But he had pain, and pain for more than 1 year. And when we actually look at the radiographic evaluation of this, as you can see on these slides, you'll see that the distance between the acromion and the greater tuberosity was almost 6 centimeters, whereas the normal acromiohumeral distance is roughly 8 to 10 millimeters. Lateral, the greater tuberosity of the acromion exceeded almost 14 millimeters. So when we evaluated this patient who had normal indices, no evidence of infection, and a reverse arthroplasty, and great function, the etiology of neuropathic pain could be from the neck, it could be from the plexus, it could be from excessive tension. So in this particular case, we sought to reduce the tension by doing this. We reduced the size of the glenoid base plate. We reduced the size of the humeral component and attempted to shorten the lengthening of the arm. Again, trying to take the stretch off the brachial plexus. So don't forget, brachial plexopathy is a cause of pain and failure as a complication after arthroplasty. This is the final case demonstrating that we were able to reduce from preoperative to postoperative the lengthening of the arm as well as the lateralization of the arm and the tension on the brachial plexus. With regard to mechanical complications, the most common mechanical complication that we're going to see is a fracture. And the incidence of periprosthetic fracture in anatomic and reverse arthroplasty is different. Anatomic arthroplasty really relates to something happening down the humeral side, whereas reverse arthroplasty really relates to something happening on the acromion and the scapula. So if we view this as a periprosthetic fracture, for anatomic arthroplasty, it tends to be traumatic. For reverse arthroplasty, it likely is something that's stress-mediated in the acromion and scapula. And the treatment is purely related to both location as well as component stability. So when we talk about periprosthetic fractures of the humerus, using the classification system by Dr. Cofield, if the stem is stable, well then performance of long bone fixation can be done as any orthopedic surgeon would with some type of plate fixation. But if the stem is not stable, we firmly believe that we need to extend that stem and revise the implant in order to obtain intramedullary stability. With regard to reverse arthroplasty, this is the same type of treatment algorithm. The location and the stability of the glenoid component with acromion and scapular spine fractures really dictate the treatment. Non-operative treatments oftentimes are as successful as operative treatments with regard to acromial fractures. But such as in this case that we see here with a fracture through the scapular spine, the amount of tension on the scapula itself is overloaded by the deltoid, and we believe that scapular spine fractures benefit from fixation. Instability. So the mechanical complication of instability really predominantly relates to reverse arthroplasty. There can be anatomic arthroplasties that are unstable, but the reverse, this is, other than infection, the most common complication that occurs. Up to 1 in 3 arthroplasties that are done in a reverse configuration, and generally within 3 months of the index surgery. There's a multifactorial etiology related to bone, soft tissue, the glenoid, and the humerus, and understanding instability of the reverse really involves understanding why it may dislocate. This is a semi-constrained implant that requires the tension of the deltoid and appropriate lateralization of the humeral shaft to allow for motion around the torso. So a loss of compression, a loss of containment, and also impingement can be the 3 causes of instability of the reverse arthroplasty. Those losses of compression, containment, and impingement can be bony issues, such as a loss of the proximal humerus, leading to a medialization of the deltoid and a lateral position of the humerus. Soft tissue effect relative to the actual rotator cuff itself, and also implant issues because of the humerus and the glenoid contacting each other. So with regard to the treatment of instability, closed reduction, that's a variable success with contemporary implants, and in our series of more than 1,000 implants, we weren't successful treating this closed in the 10 cases that we had instabilities. We required some type of revision, either bony, soft tissue, or both in combination. Component failure. And this is the final mechanical cause that all surgeons fear. We're asked by patients, how long is my implant going to last? Well, on the humeral side, we can probably say reliably that the incidence of aseptic humeral loosening is less than 1%, maybe even less than that with regard to the modern prosthesis that we use. But with regard to the glenoid on the anatomic side and the base plate on the humeral side, these are not instances that are unreal. Glenoid poly failure with an anatomic total has been reported in 6% of cases. Recent work has demonstrated that over 10 years, this might exceed 30% of cases. Base plate failure of the reverse has been reported between 1 to 2%, but might actually be more common than we think with different types of configurations. So this was sent to me by my good friend Roger Emery in London at the reason why anatomic polyethylene glenoids that are placed in an onlay fashion fail. We know Dr. Miniacci talked to you about the inlay glenoid, and you can see here on this slide that the anatomic glenoid that's placed onlaid actually has failure around the keel that's seen on a microscope because there's edge loading. There's compression at the upper part of the glenoid rim, and as we can see, distraction at the lower part of the glenoid rim, and that leads to a rocking effect and failure and a distraction load. Similarly, what we find with reverse arthroplasties is that the incidence of glenoid base plate failure is also related to similar mechanisms. This is our series over the course of 5 years. We had in more than 700 implants a 2% incidence of aseptic glenoid base plate failures. Incidentally, we had no failures if we did not use a bone graft behind the glenoid base plate. But we did have failures if we did, and the reason for this is probably related to the size of the glenoid deficiency, the bone quality that we're trying to address, the failure of ingrowth of the actual component, as well as the mechanical effects, as you saw with the anatomic glenoid, whether it's overlateralization, too much compression and distraction on one side, and a rocking horse failure of the glenoid base plate. So in summary, with regard to the management of shoulder arthroplasty, understand that preoperatively, this is a value-driven proposition between you and your patients. The best management of complications is really prevention, and those preventative measures, as you saw in the entire conference, involve preoperative comorbidity assessment, preoperative advanced imaging in order to help you plan the procedure, preoperative procedure planning, as we've seen, to help you decide what implant to do, intraoperative technical considerations. Maybe what we did 20 years ago is not what we do now. And finally, the improvement in implant biomaterials that we're seeing over the next few years will hopefully help us reduce the mechanical failures. Thank you very much.